Assalamualaikum and hello everyone. My name is Halimatun Razia Osman. I'm the scientific officer of the Hematology and Transfusion Medicine Unit, Department Pathology, Pusat Perubatan, UiTM, Sungai Buloh, Selangor. I hope you are doing well, enjoying your online lecture during this MCO period. So today, I am going to give you a lecture on autoimmune hemolytic anemia, which is part of your blood transfusion technology subject. So for this topic, there are a few learning objectives that you need to know at the end of this lecture. It is expected that at the end of the lecture, you are able to define what is hemolytic anemia and autoimmune hemolytic anemia. The next one, you are able to understand the mechanism of red cell hemolysis and to know the classification of the autoimmune hemolytic anemia, the warm and the cold type, and the differences between those two. And finally, to be able to describe the lab tests and lab findings for each category of AIHA. Okay, before we go further, we need to know the definition of hemolytic anemia. Anemia is actually a condition of low hemoglobin and the red blood cell. So when the red blood cell and hemoglobin are lower than the normal range, so it is considered anemia. So what is hemolysis? Hemolysis is actually a degradation or destruction of red blood cell before the red blood cell reach 120 days. So when we combine the word hemolytic anemia, it is actually a condition of low hemoglobin and RBC that result from premature destruction of red blood cells. Okay, in our bone marrow, the erythropoiesis process actually can expand up to 6 to 8 fold in order to compensate the anemia. However, anemia cannot be avoided when the red cell destruction exceeds the process of erythropoiesis. Okay, this is the simplified version of classification of hemolytic anemia. Hemolytic anemia can be divided into two. The hereditary, which is something to do with genetic inheritance, and the other one is acquired. It is a condition in which that the person encounter hemolytic anemia later in life. Under the category of hereditary hemolytic anemia, there are three types. They are hemoglobin defects, membrane defects, and also enzyme defect. For this one, I'm sure you have been taught about this in your hematology lecture. So let us recap. So the first one is hemoglobin defects. There is a defect on your globin chain that causes your red blood cell to be recognized as abnormal by our immune system. For example, we can see this condition in thalassemia, the alpha beta, as well as in sickle cell anemia. The other one is the membrane defects. So there is some defects on our lipid bilayer of our red blood cells that causes our red blood cell to be abnormal, and they are destroyed before the red blood cell reach 120 days. Condition can be seen in hereditary spherocytosis, elliptocytosis, xerocytosis, to name a few. So the last category is enzyme defect. As we all know, there are a number of important chemical function that occur in our red blood cells, such as pentose phosphate pathway, also glycolysis. So therefore, our body needs a large amount of enzyme in order to perform this function. However, if we lack this enzyme, our red blood cell will be in poor health, and eventually the red blood cell die prematurely and become hemolytic. So for the acquired one, it can be divided into immune and non-immune type. So for the non-immune type, it can be seen in a condition like MAHA, in which there are a presence of a number of fragmented red blood cell that become hemolytic because that is considered abnormal red blood cell. So there are infections that also can cause hemolytic anemia, such as in the infection of Mycoplasma pneumoniae. There are drugs as well that can cause hemolysis of the red blood cell, and exposure to cold also can cause our red blood cell to be destroyed prematurely. So for the immune type, it can be divided into two, which the autoimmune and also the alloimmune. Autoimmune is something to do with self-immune, the immunity towards our own cell, and the alloimmune is something immunity towards foreign cell. So we are not going to cover this topic as it will be covered in other time. Other lecturer will cover this topic. So for the autoimmune hemolytic anemia, it can be divided into three: the warm type, the cold type, and drug-induced hemolytic anemia. So we are going to cover this part in the next slide. Okay, the autoimmune hemolytic anemia is actually a clinical condition of uncompensated hemolytic anemia because of autoantibody that attach to the red cell surface. This condition presented with or without complement activation. If you remember in your immunology subject, the immunoglobulin, the Y shape, this Y shape, this immunoglobulin has the FC portion and also the FAB portion. So the FC portion of the autoantibody that attach to the red cell will bind to FC receptors on macrophages in the spleen, liver, and also the bone marrow, and are eventually destroyed by the process of phagocytosis. So FC receptors are not only presented in macrophages, but also presented in other immune cells such as the natural killer cell, B lymphocyte, neutrophil, and also the mast cell. AIHA is actually more common in females compared to males with ratio 60/40, and it can occur in any age group. The incidence of AIHA in the population based on published report is one case over 80,000 population. Okay, the autoimmune hemolytic anemia may occur as idiopathic, in which the cause is unknown. It can either be secondary, which is associated with underlying disease, such as in systemic lupus erythematosus, which is the autoimmune disorder. It can also be associated in lymphoproliferative disorders, such as in lymphoma and also chronic lymphocytic leukemia. Viral infections such as in Epstein-Barr virus infection, the use of drugs such as the use of metidopa, and also in the post-hematopoietic stem cell transplant. Throughout my experience, I have encountered one case, one pediatric case in which a patient presented with severe anemia, jaundice, and also the enlargement of spleen. Um, we cannot anticipate AIHA because typically AIHA is acute in onset. At presentation, the patient red cell may be coated with antibody and complement, or can either be antibody or complement. AIHA can be classified into warm and cold type. The warm type involves IgG type of autoantibody. However, for cold type, it involves IgM autoantibody. So as we all know, IgG is reactive at 37 degree, and IgM is reactive at 4 degree. So that is the reason why AIHA is classified into warm and the cold type. There is another one of AIHA, one type of AIHA, which is the drug-induced autoantibody. The patient experience recurrent anemia when using the specific drug. However, the anemia recovers when the drug is discontinued. Okay, before we discuss further the cold and the warm AIHA, we need to know the mechanism of red cell hemolysis. So the red cell hemolysis can occur either extravascular or intravascular. For intravascular, the hemolysis, the process occurs within the blood circulation. For extravascular, the hemolysis occurs in the tissue, which involves reticular endothelial system, which also known as RAS. This RAS includes the macrophages in the spleen and also in the liver. For this condition, normally hemolysis can cause hemoglobin to drop. However, in some circumstances, the hemoglobin may be normal if there is a sufficient compensation by the erythropoiesis. For hemolysis that occurs extravascularly, this is how the red cell come into contact with macrophages. As we all know, the macrophage contains the Fc receptor of the Fc portion of the red cell autoantibody. So when the macrophage come into contact with the red cell, the macrophage will start to engulf and eventually phagocytize the red cell. Okay, the continuation from the previous slide. Once a macrophage bound to the RBC surface, there will be three pathways how the hemolysis occur. So there will be a fragmentation of RBC to spirocyte. This will cause the shortened lifespan of the RBC. And then the other pathway is RBC will stay outside of the macrophage and eventually is lysed by the antibody dependent cell mediated toxicity, which also known as cytotoxic T cell in the spleen. And the other pathway is RBC is engulfed and destroyed by the macrophage. Okay, it is important for you to know the importance of Fc gamma receptor. So the macrophages contain this Fc gamma receptor that eventually recognize and phagocytize the IgG heavy chain and a portion of the RBC membrane, and therefore it will produce a spirocyte. The cytotoxic T cell in the spleen also carry Fc receptor and can cause cell-mediated cytotoxicity of the red blood cell. And the hepatic macrophages have the receptor for C3 fragment, the complement fragment, and can also phagocytize the RBC, which is coated with the complement. Okay, we move on to intravascular hemolysis. So intravascular hemolysis, as we discussed earlier, it occurs in the blood circulation. So how this thing can occur? This is because of the full complement activation, which will lead to intravascular hemolysis. This occurs in a very severe case in which the complement cascade is fully activated. So in this diagram, it shows the phase by phase on how the complement activation occurs. So the first phase is the activation phase, which start with antigen antibody complex. So the next phase is the amplification phase, and the final phase is the membrane attack phase. So this formation of membrane attack complex, which is deposited on the RBC surface, this formation, the MAC complex is strong enough to form a hole on the RBC and eventually cause the RBC to lyse. Okay, we move on to the lab approach in performing diagnosis of AIHA. The first important test that is needed to rule out anemia is the complete blood count. From this test, we are able to know whether the patient is anemic or not through the RBC and hemoglobin value. So if the patient RBC and hemoglobin are lower than the reference range, it is suggested that the patient has anemia. So the next important thing is to know the red cell indices, the MCV and MCH. From these two red cell indices, we are able to classify the anemia, whether the anemia is normocytic normochromic anemia or hypochromic microcytic anemia. So the next important test that the clinician may request is the reticulocyte. Reticulocyte count is important to differentiate whether the anemia is chronic type or acute type. The clinician may request for peripheral blood film. For this test, it is important for pathologists to look for spirocyte cell, which is common which is always present in hemolysis case. So the next important test is this polyclonal direct comb test. If the direct comb test is positive, only then we will perform the extended direct comb test. So the extended direct comb test is important for us to know whether the hemolysis involves the IgG and C3d, or whether it involves either IgG or C3d. C3d is complement. So the next important chemical pathology test that the clinician may request in ruling out the hemolytic anemia are the haptoglobulin and also the lactate dehydrogenase test, LDH. I want to share a case study of one AIHA. This is the blood count of a male patient aged 69 years old, presented with chest pain. As you can see here, the patient RBC and hemoglobin are low. Hemoglobin is 80 gram per liter and the RBC is 2.37 times 10 to the power of 12 per liter. So the RBC indices, the MCV and MCH are normal. So this is considered a normocytic normochromic anemia. So this is the blood film of this patient. There is a presence of numerous spherocytes with large size of RBC, bluish RBC, which is known as polychromatic cells. The spherocytes are the red cells, which is small, dense, and has no centropelon. So majority of red cells are spherocytes. This is a typical AIHA case, but you have to be very careful not to wrongly diagnose as hereditary spherocytosis. Both hereditary spherocytosis and warm AIHA presented with almost similar peripheral blood features. So therefore, you have to be careful to correlate with the age and also the clinical history. Okay, these are the detailed finding of the patient from the previous slide. As I mentioned earlier, the RBC and hemoglobin are low for this patient. There are RBC changes being observed with the presence of spherocytes, nucleated RBC, mild RBC agglutination, and also increase in polychromasia. Polychromasia refers to bluish RBC that are present in significant numbers in the blood smear. Actually, these polychromatic cells are reticulocytes. The RNA content in the retic, when react with methanol-based stain, it will diffuse and become bluish. WBC and platelet are not our concern now. This patient also has high reticulocyte count. The normal range for retic is less than 2.5%. In active AIHA, the percentage of retic can go up to more than 10%. Because of active hemolysis, patient bilirubin also increase. Okay, we need to be careful not to wrongly diagnose warm AIHA with hereditary spherocytosis because the red cell changes are almost similar. However, we need to take a look on the patient's clinical history and also the age of the patient. This patient also has increased LDH, which is due to RBC breakdown. However, haptoglobin is reduced in warm AIHA patient because the haptoglobin the haptoglobin is a good indicator to determine AIHA, as the value may drop because haptoglobin will bind to free hemoglobin. If more free hemoglobin are present due to RBC breakdown, therefore more haptoglobin will bind to it. Okay, for blood bank finding, this patient has a positive DCT with positive IgG and complement C3d. Now, I want to show gel cup which is used to perform DCT in the laboratory. By the way, DCT can also be done using other methods such as using tube method. So in this left picture, it shows a polyclonal card which is used to perform DCT. DCT is direct comb test. So negative result is seen when there is a formation of complete button at the bottom of the column. Positive result is seen if there is an agglutination in the gel column. Positive reaction has to be degraded from 1 plus to 4 plus. So when the DCT is positive, then we can proceed with extended DCT. For extended DCT, we need to use a different type of card, which is a monoclonal type. So this card is used to differentiate whether there is a presence of IgG or complement specificity. So in this right picture, it shows extended DCT with IgG specificity. Okay, now let us move to cold AIHA. Cold AIHA is also known as cold hemagglutinin disease. Unlike warm AIHA, cold AIHA is caused by autoantibodies IgM. The IgM antibodies are special because they are the largest antibodies. They are found as pentamer, in which the J chain at the center that hold the 5 immunoglobulin together. So these antibodies are active at low temperature between 4 to 10 degrees. The disease is usually found in middle age or elderly when they are exposed to cold condition that eventually develop hemoglobinuria. This IgM can fully activate the complement causing intravascular hemolysis. However, sometimes IgM can just stick to the red cell and form a complement coated red cell. So hemolysis results from the interaction of this complement coated red cell with macrophages in the spleen and liver. Okay, I would like to share one interesting case study that we encounter in the lab. So the initial investigation is by sending a sample for blood count. So upon testing, the machine gave a very weird result. The MCHC is very high, as the normal MCHC is between 31 to 35 gram per deciliter. If you learn hematology, you will encounter the rules of three, in which the hemoglobin is actually the value of 3 times RBC, and the hematocrit is 3 times values of hemoglobin. So bear in mind that this rule is not applicable for thalassemia case. So back to our discussion, back to our case study. The patient doesn't follow the rules of three. But one significant finding, you will notice that the machine gave RBC agglutination flag. So what we should do with this result? So it was suggested for the sample to be incubated at 37 degree for about 15 to 20 minutes. So you would notice that the RBC, hemoglobin and hematocrit are now following the rules of three. So the value of HB is 3 times RBC, and the value of hematocrit is 3 times the value of hemoglobin. Okay, the MCHC also become normalized, and there is no more agglutination flags seen in this machine's result. So the history of patient blood count. In July 2019, the patient count was normal and followed the rules of three. But suddenly, the result was out of order in March 2020. So when we encounter this kind of result, it is suggested to incubate the sample. We should not release result before incubation because the result is invalid. After blood count, we may proceed to perform blood smear. If we delay in making blood smear and the sample become cold, we will notice autoagglutination on the wall of the blood tube. This autoagglutination is reversible. The red cell agglutination dissociates when we incubate the sample back. When we are making a blood smear, we have to ensure that sample and glass tube to be warm up first in order for us to get a nice blood smear, which is shown here. If we don't warm the slide and the blood smear is done at room temperature, the blood smear will become like this. Actually, we can easily notice cold AIHA when, after making blood smear at room temperature, you will notice auto-agglutination in the blood film. This is the microscopic view of the red cell agglutination. However, for PBF reporting, it is hard for pathologists to make a PBF report using this auto-agglutinated blood smear. Therefore, the blood must be warmed up first to get an acceptable blood smear. Now we move on to management of warm AIHA. The patient may be given folic acid to support erythropoiesis. Splenectomy may be performed if red cell hemolysis is out of control, even the patient is given a low dose of steroid. It has been reported that 60% of patients reach remission status after splenectomy. Normally, steroid is given first. Agents like dexamethasone and methylprednisolone may be given. Um, how does steroid work? It works by two mechanisms. It reduces the antibody formation, and it also inhibits the macrophage function. About 70% of patients responded to this treatment. Managing warm AIHA patient is one of the most challenging tasks for us blood bankers. Patient may require transfusion when red cell hemolysis is too overwhelming and patient becomes too anemic. As usual in the blood bank, patient sample needs to undergo pre-transfusion testing before blood transfusion. This pre-transfusion testing consists of blood grouping tests, antibody screening, cross-match, and also autocontrol. A problem arises when warm AIHA patient shows positive antibody screening in all three reagent cell panels. This reaction has similar strength in all three cells panel, and this is what we call pan-agglutination. Patient will also shows positive autocontrol. Uh, Autocontrol is actually a reaction of patient plasma with patient own cell. When patient shows a pan-agglutination reaction, it is almost impossible to find compatible blood, as autoantibodies will react with all red cells. It is rather difficult if a patient has a mixture of autoantibodies and alloantibodies. Okay, the main purpose of blood transfusion in warm AIHA patients are not only to correct the anemia but also to slow down the rate of hemolysis. Warm AIHA patient is likely to tolerate serologically incompatible blood without serious complication. So several specialized techniques have been established, such as autoadsorption and elution techniques in resolving warm AIHA case. However, this technique cannot be performed by blood bank which handle basic transfusion testing. It has to be referred to specialized lab, as the technique require highly specialized and also experienced lab staff. In our lab, we normally refer this type of case to National Blood Center. Okay, let me explain a bit about elution and autoabsorption technique. The purpose of this technique is to separate autoantibodies that attach to patient red cells. Elution is done first to detach the autoantibodies. This will leave autoantibodies and alloantibodies in the plasma. So the next step is to mix the patient red cell with the mixture of allo and autoantibodies, and this technique is known as autoadsorption. So the remaining antibodies in the serum are the alloantibodies. The lab staff needs to identify whether the antibodies that attach to patient red cell are similar to alloantibody that are present in the plasma. So this technique is very time consuming and may delay blood transfusion. Sometimes even many techniques are involved, we still could not resolve this warm AIHA case. So if transfusion is needed, a patient may be transfused with least incompatible blood. Least incompatible blood refers to blood that has the weakest incompatibility reaction among the blood being cross-matched. So this is the example of a statement given by National Blood Center when this compatible blood is supplied to the patient. Okay, the auto-absorption has its own drawbacks. So this technique cannot be used for recently transfused patient. Some autoantibody are difficult to absorb. Titer may be too high, and the patient's RBC may be fragile to work with. This technique is time consuming as it is not easy to find least incompatible blood after elution and auto absorption are performed. Sometimes more than 10 pints of blood needed to perform cross-match, and it is not guaranteed to find the suitable one. This technique also require high volume of sample, and therefore nowadays molecular method came into picture in resolving warm AIHA cases, especially the difficult one. Only referral lab has the technique, so the small lab like us could not afford to have this advanced technology because of the low workload of AIHA patient. Management of cold agglutinin disease is less complex compared to warm AIHA. This is because the patient only suffers episodes of anemia after exposure to cold. Therefore, it is important to keep the patient warm. After all, our body temperature is 37 degrees. So therefore, the auto antibodies are less likely to be reactive unless patient is exposed to cold condition. Alkylating agents such as chlorambucil may be helpful. However, splenectomy and steroids are reported to be unhelpful. Okay, I guess that's the end of my lecture. I hope this lecture will help you to further understand autoimmune hemolytic anemia. So these are the references that you can refer to further understand this topic. So I guess that is the end of my lecture. I can be contacted using this email. Feel free to contact me if you don't understand about this lecture. I would also like to apologize if this lecture doesn't have that extra animation to make you understand better. So that's all for now. Assalamualaikum and all the best.